All right, so continuing our talk about bleeding. So the clotting process we talked about a little bit already. Bleeding itself tends to stop rather quickly in most people, generally about 10 minutes. And this is response to internal mechanisms as well as exposure to air. So when the skin's broken, blood ends up flowing out of that vessel. The cut ends of the vessel start to narrow, which vasoconstriction, to help reduce the amount of bleeding. The clot forms, plugging the hole seals that injured portion of the blood vessel and then leads to coagulation. Bleeding will never stop if a clot doesn't form unless an injured vessel is completely cut off from the main blood supply, such as direct pressure or a tourniquet. So a form of problems with clotting is hemophilia. So this patient with hemophilia would lack one or more of the blood's clotting factors. Remember how I said it was a cascade? One thing happens kind of like dominoes. Well, if you take a couple of dominoes out, now all of a sudden it's not going to work as efficiently. There's several different forms of hemophilia. Most are hereditary. Some can be pretty severe, and bleeding may occur spontaneously in those patients. All injuries, no matter how minor they are, can have the potential to be very, very serious. So patients need to be transported um, immediately if they have hemophilia. Internal bleeding. So this is any bleeding that goes into a cavity or a space within the body. It can be very serious just alone by itself or because it goes undetected for a while. Injury and damage to internal organs often results in extensive internal hemorrhage, which can lead to hypovolemic shock. Some possible conditions that cause internal bleeding are stomach ulcers, lacerated livers, ruptured spleens, broken bones can do it, especially the ribs or a femur fracture. Femurs themselves just tend to bleed a lot. Ribs don't bleed overly significantly, but there's a lot of structures that those ribs can hit up against, causing them to bleed. So definitely not something that we want. And then pelvic fractures. The pelvis, when broken, bleeds a lot. And part of it is just that it has so much room to fill up that it doesn't get any compression on it once it starts to bleed. Oftentimes, internal bleeding can cause uh, contusions or ecchymosis, but oftentimes it's going to be more us with our high index of suspicion that's going to pick up on internal bleeding because those two signs are going to be relatively late. So what we want to keep in mind is that the greater the mechanism of injury, the more we should be thinking about unseen injuries. Internal bleeding is definitely possible whenever the mechanism of injury suggests that there are several severe forces that have affected the body, and it can be in either blunt or penetrating trauma. When we're assessing for different signs of injuries, we use the mnemonic DCAT BTLS. So that stands for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. And then just kind of being on the lookout for other different types of signs for injury. The nature of illness for internal bleeding is not always caused by trauma. Possible non-traumatic causes are things like bleeding ulcers, bleeding from the colon, from a gastrointestinal bleed, a ruptured ectopic pregnancy, aneurysms, and there are several others, but we'll just stay with those. Different signs that are frequent but not always present. The most common is pain, generally abdominal tenderness, guarding, rigidity, distension can be seen often. In older patients, signs include those of shock, so dizziness, faintness, weakness. They may vomit blood. They may have bloody diarrhea or urine. So it's just more what you need to look for in the area because there are several different signs, but a lot of times we're not going to pick up on them right away. Here's some more signs here: broken ribs, bruising. If they have low blood pressure and there's not a visible reason why, just suspect that they're probably bleeding somewhere, unfortunately. Remember, the first sign of shock that we're truly going to be able to pick up on is pale, cool, clammy skin. The true first sign is actually tachycardia, but oftentimes we attribute that to anxiety, so we can't say for sure that that's what it is. For our patient assessment, scene size up. With everything else, we want to be safe first and foremost. You want to keep in mind that if you're at like a vehicle crash, that there may be fluids leaking, energized electrical lines. You have the potential for the scene to be unstable around you. So if they hit a tree, maybe something's going to fall off of that tree or the tree itself is going to fall. So just make sure that you're doing a thorough assessment of the scene to make sure it is in fact safe for you. You're going to determine that mechanism of injury, nature of illness, based on the factors that you see at the scene. Consider the need for spinal immobilization. A lot of the time, spinal immobilization is going to be used as a precaution. Granted that nowadays we are starting to move away from fully spinal immobilizing a lot of patients, but follow your protocol on that. And then make sure that you don't need any additional resources. You might have a patient that you can manage everything but their pain. And if the pain is causing them significant discomfort, causing their breathing to be shallow, things like that, you may need to call ALS for none other reason than pain management. For your primary assessment, don't get distracted by those non-life-threatening injuries. Again, they can be very gruesome when you're looking at them, but if they're not severely bleeding, I'll take care of that later. Most patients that have some sort of open traumatic injury are going to get antibiotics as part of their care. So I'm not worried about cleaning it out. And that's something that we can take care of once we've taken care of all of the life threats. And sometimes we're so busy taking care of life threats that we don't even get onto a secondary assessment. So just keep that in mind. You'll get your general impression. Make sure that you're looking for indicators that say, hey, this is a sick patient. A lot of times you'll just get that gut feeling of something's not right. Trust that instinct. Perform a rapid exam, just looking for life threats, life-threatening external bleeding, assess your skin color, and then determine your level of consciousness using that APU scale. For airway and breathing, consider that you need spinal immobilization. So if you do, open the airway appropriately so that you don't compromise that spinal, that C-spine. Look for adequate breathing. Check for breath sounds very early on trauma patients that have the potential to have thoracic involvement, just to make sure that you're not dealing with a pneumothorax or a collapsed lung, because how you treat them may be different. If the patient is unconscious, you're probably going to want to insert an OPA unless their gag reflex is still intact. If it is, try an NPA. See if that helps for you. Circulation, assessing the pulse rate, quality, rhythm, looking again at skin color, temperature, and texture now that you're actually touching the patient. Control external bleeding. Now, this is not the scratch on the leg. This is legitimate external bleeding. treat for your shock by applying oxygen, trying to improve circulation. That's one thing that we haven't talked about a whole lot. But if they have on tight clothing, um, you can loosen that to help out. If they have tight shoes on, maybe we want to take the shoes off so that it doesn't have a place for blood to pool because of swelling. And then maintain a normal body temperature as much as possible. So cover them up with a blanket to keep that heat in. For your transport priority, most of the time on our trauma patients, we're not going to play around on scene. They need to get to a hospital, even for non-life-threatening injuries, because we can't set a broken bone in the field. We can't sew up a deep laceration. We can't adequately take care of their pain on a BLS truck. So no matter how bad they are, their definitive care is still outside of our scope of practice. So some patients are going to require more rapid transport than others. Those that are tachycardic or tachypnic, those with hypotension, those whose pulse is weak and thready, and then those who have that pale, cool, clammy skin, aka showing signs of shock, even if their blood pressure is not showing it yet. They are ones we definitely don't want to play on. Investigate your chief complaint. Look for signs and symptoms of other injuries because of their NOI or MOI. Because they're complaining of something doesn't necessarily mean that that's the worst thing that's going on with them. So it's always good to ask them where they're hurting and what hurts the most, but that doesn't mean that's the only thing that is going on with them. You want to ask the sample history on trauma patients that are really unstable but are conscious to begin with. You might want to ask them a couple of questions before you actually package them up, just in case you end up losing consciousness on the transport into the hospital. So some big ones, blood thinning medications, and then any allergies are the two big ones. And since BLS trucks won't be giving medications, the allergies one is kind of here nor there. But if they're on a blood thinning medication, we want to know about it. That does change the urgency of their treatment. Look for signs and symptoms of shock. If your patient is unresponsive, they may have medical alert tags. You might need to ask some questions from bystanders, but we're typically not going to delay transport because we're looking for medical ID bracelets. For your secondary assessment, you want to record vital signs early on so that you can look for trending. If their blood pressure is less than 100 millimeters of mercury, if you have a weak rapid pulse, you definitely have hypoperfusion, not just hypotension, but hypoperfusion. Your patient is not doing fantastic. So we need to get moving rather than conduct a secondary assessment on scene. If you do get the opportunity to do a secondary assessment, basically what we're going to do is start from the head and move our way down, looking for DCAT BTLS. And now we're going to take care of some of those secondary injuries that weren't life threats when we first started. For looking for signs of internal bleeding, we want to actually put hands on the abdomen. We actually want to continue to take additional blood pressure so that we can catch shock early. Some of our older patients may be on medication that prevents them from compensating, so we might not see their body react the way we would expect it to. If for some reason the blood pressure is not what you expect, try and see if you can determine their baseline blood pressure, and then see if there's any medications that they're taking that could affect that as well. We'll continue in the next.